Well, good morning, everybody, and thanks for joining us again on this crisp Thursday. Feels more like autumn than spring, but still beautiful outside, and really, once again, so happy to have you all with us. I'm going to pass the mic to Dr. Yusuf Ali, who everyone will know is our chief of the Division of Rheumatology at Mount Sinai Morningside and Mount Sinai West, to introduce today's distinguished speaker.
Yeah, thank you. Thanks, Samuel. And so today, really happy and excited to introduce a friend and colleague, Marguerite Wiesendanger, who's our esteemed fellowship director over at MSH. And she trained at Albert Einstein, and then she did her MD. She did an MD, PhD at Albert Einstein, and then did most of her career at Columbia, where she worked in Bob Winchester's lab and has an interest in T-cell trafficking and immunologic therapies for lupus and scleroderma and so on. And today she's going to be educating us about scleroderma. And really delighted to have you, Marguerite, and thank you for coming and educating us. So take it away.
Well, thank you so much for this kind introduction, Dr. Seward, Dr. Ali. And I'm going to go ahead and share my screen. Yes, here we go. All right, can everybody see and hear?
Yeah, perfect.
Yes, good. All right. So I'm going to talk about scleroderma. I like to call it a toxic brew of inflammation, vasculopathy, and fibrosis, because it is a tricky condition in many ways. So I have no disclosures for financial support. I'm going to speak a little bit about the clinical phenotypes first. And the reason for that is I feel like reading about scleroderma is like trying to read Shakespeare just from a book. It's confusing, and there are many characters, and it doesn't really make a lot of sense. So whereas seeing it performed live, then now that's something that you can get hooked into. So my hope is that I can interest you in this difficult condition and tell you some new things that are happening. I'll talk a little bit about diagnosis and staging, what is known about pathophysiology, and then what new trial results have come to bear in the last couple of years. So the challenge for systemic sclerosis stems from the fact that it's a very heterogeneous disease in terms not only of the skin involvement, but what types of internal organs could be affected in an individual patient. At the same time, it's really rare. A prevalence of only 200 per million, incidence fewer than 10 to 20 new cases per million per year. And yet it carries a very high burden of morbidity and mortality. The SMR being 3 to 4.7 by different estimates, and the 10-year survival being only 60 to 75%. As I mentioned before, inflammation, vasculopathy, fibrosis all contribute to the pathophysiology, and it's been difficult to find a disease-modifying therapy. So there are many types of scleroderma, and I'm going to focus my remarks today on only the systemic forms, which are, even they are 3 different types. You can classify them based on the amount of cutaneous involvement, from diffuse cutaneous to limited cutaneous, or no skin involvement at all, scleroderma, Sinai scleroderma. But what they have in common is that they affect internal organs, which is different from the localized scleroderma, morphia and linear scleroderma, which I will not discuss today, overlap syndromes, and then scleroderma-like syndromes that are induced by toxins or drugs, or this other condition, eosinophilic fasciitis, which resembles scleroderma but is very distinct. So let's first talk about the skin. What's going on with the skin? So clinically at the top and pathologically at the bottom of the slide, what I'm doing here is I'm showing you the progression from early on. It's the edematous phase, where the skin, where you see puffy hands and fingers, but the skin is normal. Here's the epidermis, and then the dermis still has all the normal appendages, the hair follicles, the blood vessels, they're all there. And then in the second phase, the skin becomes thicker and more attached, more tethered, and you start to see a lot of inflammation in the dermis again, here. Followed by more severe disease, acrosclerosis, contractures can occur because of all the scar. And what's happened here is the epidermis is still okay, but the dermis has been replaced by fibrosis. There's a loss of the blood vessels and hair follicles. The skin becomes very tight and smooth and hairless and no blood and ischemic. So by this point, it's sort of too late. So the challenge has been, what can we do to bend the arc of this disease? So rheumatologists check the thickness of the skin physically. And this is sort of a routine exam that we do, which is also used in research trials when it's quantified. So I just want to show you what this is, because it's has to be sort of standardized. The score of the skin thickness goes from 0 to 3. 0 means normal, no increased thickness, and you can elicit fine wrinkles when you use 2 fingers to sort of create a skin fold on the patient's hand or foot or limb or torso. So what you're doing is you're trying to bring together a fold of skin, lift it up, and see how thick the dermis is. So with 0, it looks like this. And then 3 is also pretty easy to assess. The skin thickness is so severe that you cannot create a skin fold. It just slides under your fingers, and that's that. So a little more tricky is to distinguish 1 from 2. 1 is a mild increase in thickness where you can still easily grab the skin and make a fold, and you can create 1 wrinkle. Whereas with 2, the skin thickness is moderate, not as severe as 3. It's moderate thickness. It's difficult to make a skin fold, and there's no wrinkling at all. So this is what ends up being used as a measurement of the severity and distribution of the skin. And that's important because different skin distributions and severities help you understand what's happening with the patient. So the 3 main categories, as I mentioned before, is a patient with no skin thickening whatsoever, but still with the classical scleroderma internal organ features. That would be this person, normal skin, but they have maybe heart or kidney problems. And then you have limited cutaneous systemic sclerosis. This is distribution. The face is involved, the hands up to the elbows, the arms from the fingertips to the elbows, and the legs from the feet, the toes to the knees. So this would be limited cutaneous. And then diffuse cutaneous can also involve the proximal limbs and the torso in addition. So what we're doing with this is we're, with the modified Rodnan skin score, we're counting the different body areas and adding up the numbers from 0 to 3, and we come up with a score up to 52, and that says, okay, how intense. So you can follow over time how our patient's progressing. So you can sort of mark the velocity of the skin thickening. You can sort of predict to some degree what sorts of internal organ manifestations may occur. But you have to keep in mind that some of these measurements that we do, and that I guess you could say it's fairly crude because you're basically just estimating by bringing your fingers together on the skin of the patient. You have to keep in mind there's things that can create the illusion of skin or dermal thickening, but they're not. So they include a lot of edema. So if there's a lot of peripheral edema, that's going to not allow you to make that determination. If they've lost a lot of subcutaneous fat, it will seem that the skin is tethered. And if there's just a lot of soft tissue swelling. Over time, the skin fibrosis may become altered even without applying any medicines. So there is a natural history to scleroderma where after the first year, there may be some softening that occurs even if the patient's not treated. But what about what's happening under the skin? There are many organ complications to keep in mind, some more frequent than others. Among the most frequent is Raynaud Phenomenon, 90% of patients, often preceding the other symptoms by up to 10 years. Gastrointestinal complications in 90%. This would be mainly esophageal dysmotility, but the entire gut can be involved. Musculoskeletal problems in 65%, telangiectasias in 75%, and then the dreaded interstitial lung disease in 40%, and renal crisis in 5 to 10%, pulmonary arterial hypertension in 15%. So let me show you a little more about Raynaud phenomenon. This is an inappropriate vasoconstriction of the digital arteries. Here I'm showing you the pallor phase, but some patients have triphasic changes. They start out with pallor and then cyanosis and then followed by red hyperemia as the skin is reperfused. It's a very painful condition. It can be brought on by anything that activates the sympathetic system, like very cold weather or stress. Unfortunately, some of these patients further develop ischemic changes. And these are the hands of a patient who was seen just last week in dermatology clinic. And I was called to see her as well. And she's showing us all of the spectrum of ischemic changes that can occur with severe Raynaud phenomenon. So here you have fingertip pitting scar. It's a little hard to appreciate on this picture, but there are these little dry pits here at the fingertips. She also has digital ulcers. And this one is deeper here. So these ulcers can become infected and lead to loss of the digit. So that is the worst type of ischemia that we can see. How can we tell if a person in the clinic with Raynaud phenomenon has a high likelihood of scleroderma, or because so many people have Raynaud phenomenon just by itself, in which case it's called Raynaud's disease, and it's benign. It is annoying. Certainly they have to take preventive measures, but it's not necessarily, doesn't have that bad prognosis. So one way to look is by observing, are there nail fold capillary abnormalities? And you're looking you're enhancing this view of the fingertip just proximal to the nail. Normally, all the little capillaries kind of have this little hairpin turn right at the nail base. And that's a normal appearance. But in scleroderma, some of the vessels become dilated and some are lost. This is called dropout. So this is actually microscopy. You have early on, okay, so here's normal in the lower right-hand corner, a bunch of neat little nail folds, capillaries, all in a row. They're all the same, they're symmetric. And then early on, you start to have some abnormalities. Some are bigger than others, and you have a little hemorrhage. And then later on, you're losing a lot of these blood vessels. So this actually, to see this level of detail requires a microscope. But in the clinic, you can use a dermatoscope. So it's not as close up the view, but these are some pictures I took from my patients where even with this simple tool, you can appreciate that there are numerous dilated capillaries here. Here's one. So this is a way to prognosticate. There are other vascular anomalies that can occur in scleroderma, including in the stomach here with these vascular ectasias, some of which can lead to hemorrhage. But most of the complications are due to fibrosis and dysmotility. So the esophagus doesn't move normally. You have a lot of GERD. Here's just an esophagram showing that. In the colon, white mouth, the reticuli can form. And because the colon doesn't move normally, there's bacterial overgrowth syndrome that can lead to diarrhea, and it's malabsorption as well. And once it reaches this stage, it's quite difficult to treat. Again, because fibrosis has occurred. In the lung, you can have both vasculopathy here and interstitial fibrosis shown here. So here you've lost the normal architecture of the alveoli, and it's just replaced by all this scar tissue. You can see it on chest X-ray, you can see it on CAT scan. In the kidney, this is the dreaded renal crisis, another vasculopathy phenomena where you have onion skin appearance of the arteries and then just chokes off the glomeruli, leading to renal failure. Pulmonary arterial hypertension has been appreciated more recently than renal crisis as a complication of certain subtypes of scleroderma. It can be very subtle. It's best to monitor or screen for this because in the beginning, the patient may not be symptomatic. So I've shown you all the characters in the play. So now I want to tell you a little bit about the updated ACR Euler criteria for classifying systemic sclerosis, because although these criteria, like all the rheumatology criteria, are designed for research trials to make sure that we're enrolling the right kind of patient, they do help clinicians because they emphasize the most specific components of scleroderma. And it's a point system. So this is another trend in rheumatology. Instead of saying you need 2 major and 4 minor or some combination of different criteria, and then you sort of know whether this is a diagnosis that you can entertain. In this case, you look at the patient, see everything they have, add up all the points, and then if you have more than 9 points, then you can be reasonably confident you're dealing with scleroderma in this case. So if you have skin thickening of the fingers of both hands that extends more proximal than the MCP joints, okay, that's 9 points right there. So that's all you would need. But let's say that the patient in front of you is early on. So again, this is an advantage of the new criteria, an attempt to capture patients earlier on in the course. Let's say the skin thickening is distal to the PIPs. So they wouldn't meet this criterion on the first one. But or what if they're even earlier in the puffy phase, the early edematous phase? Well, you can still get 2 points for the edematous phase, 4 points for sclerodactyly. And then you can look carefully, are there digital tip ulcers like I showed you, or pitting scars at the fingertips, because those give you points. Telangiectasia is 2 points. If you have a dermatoscope or just use your ophthalmoscope, you can find abnormal nail fold capillaries, that is 2 points. If you do a CT scan or an echocardiogram or a pulmonary function test, you can determine if the patient has pulmonary arterial disease or interstitial lung disease. You only get to score this once. So even if they have both of these manifestations, they get a maximum of 2 points. Then you have Raynaud Phenomenon, 3 points, and 3 classic scleroderma-related autoantibodies, the centromere, topoisomerase, also known as SEL70, and RNA polymerase 3. If you have one of those, and typically there's only one per patient, then it's 3 points. So this is the new way to score and assess a patient. But it's really not one disease. It's probably many. I mean, it depends. Are you a lumper or a splitter? So as time goes on, we're finding more and more antibodies that are associated with this disease. These are all ANAs, by the way, in different patterns, anti-nuclear antibodies. But when you subtype them, you can find that it's either topoisomerase, centromere, or RNA polymerase, as I already mentioned. But you have also fibrillarin antibodies, U3RNP, THTO, and then newer antibodies have been found that are recognizing endothelial cells, fibroblast components, extracellular matrix proteins, platelet-derived growth factor receptor, and even this one here, NAG2, which induces endothelial cell apoptosis. So there's a high likelihood that these antibodies are actually doing harm, that they're pathogenic. So this is what we know about the new antibodies, what their putative role would be. And then just to mention that there are certain clinical features that are associated with specific classic autoantibodies. For example, Topo1 SEL70, that's the classic diffuse cutaneous scleroderma with pulmonary fibrosis, where centromere is the limited cutaneous scleroderma with pulmonary hypertension. RNA polymerase 3 is associated with more renal involvement, the renal crisis, and diffuse cutaneous disease. So as I mentioned, ANAs are seen in more than 95% of systemic sclerosis patients. They're usually present at the onset of symptoms, so it's high yield to check. Patients don't tend to switch to different specificities during their disease. And again, they are associated with certain clinical features. So they can be used to monitor the patient, make therapeutic decisions, and give them some measure of prognosis. However, it's not as cut and dried as I would have you, as you may be led to believe, because it's not, there are sort of different risks, different amounts of patients who have the different organ involvements, but it's not a pure situation where you have only the topo getting pulmonary fibrosis. So this is just a table showing, to give you a little more nuance about what happens to these patients. So for example, if you're topoisomerase positive and have limited cutaneous, then you still have the pulmonary fibrosis risk. 86% of patients at 15 years have it. Same as with the diffuse cutaneous. So just if you have topo antibody and you limited skin, you're not off the hook when it comes to pulmonary fibrosis. it seems that the antibody is driving the organ involvement more than the amount of skin distribution. Similarly, renal crisis. Yes, it is seen in RNA Pol 3 positive patients, but it's not exclusive. There are other subsets that can have renal crisis, and these RNA Pol 3 patients are also at high risk for pulmonary fibrosis. So just kind of mentioning that. Okay, so what do you do with your patient? Here's your patient. You're taking a history, you're doing a review of systems. They have Raynaud Phenomenon, let's say, and skin changes, chest pain. So you're sort of figuring out they may have shortness of breath, edema, bowel dysmotility, GERD, joint pain, muscle weakness. So now you want to know, is this someone who has scleroderma? You would, of course, on physical exam, look for abnormalities in the vital signs, including pulse oximetry. Look at the skin, and the highest ideal place to look is the face and the hands, basically. I don't think it's, if one is trying to diagnose this disease, it's not necessary to do a full Rodnan skin score as they do in clinical trials in order to sort of decide what's happening. So you would look for the dermal thickness, for sclerodactyly, telangiectasias, fingertip lesions, nail-fold capillaries, and then listen to the heart, to the lungs. Perhaps there are dry crackles at the bases. Look for edema, check the pulses. And then in terms of musculoskeletal, joint line tenderness, proximal myopathy, right? So this, like in dermatomyositis, polymyositis, the proximal muscles are affected first before the distal muscles. This is the only time that a rheumatologist will put their stethoscope on a joint, is to hear the tendon rub. So this would be, for example, at the wrist. This would be a way to determine if the tendon is starting to be encased in a fibrotic tissue. So then what about testing? In round one, ANAs, but only the ANA. I would not necessarily recommend checking every ANA-related antibody right off the bat, because if the ANA is negative, this is a pretty good negative predictive factor. But once you're sort of more certain that you're dealing with scleroderma, you'll want to stage the condition with CT of the chest, electrocardiogram, echocardiography, pulmonary function test, because the DLCO will be preferentially reduced even before the FVC changes. And then you can check for renal involvement with urine studies. If you have more than 9 points, as I said, scleroderma highly likely. If not, consider another diagnosis, or maybe it's early disease. And we watch the patient. Okay, what's happening in scleroderma? So this is a subject of intense debate. I like this picture because it shows a little more about how everything is kind of coming together. So early on, you have your normal blood vessel, no symptoms. Here's your normal blood vessel with a nice lumen and happy endothelial cells and just sort of regular fibroblasts around here giving support. But then things start to happen. The endothelial cells undergo apoptosis. This is an injury which is then responded to by forming scar tissue. Collagen starts to accumulate here, and then finally it's obliterating the blood vessel. So the question is, what is the role really of these antibodies? As I mentioned, some of these antibodies are primed to participate in this injury because they recognize platelet-derived growth factor or endothelial cell markers or fibroblasts, and may create a situation in which the fibroblast is encouraged to deposit collagen abnormally. So what's really going on? A lot of collagen is being put down, hyaluronic acid, fibronectin, proteoglycans, and they're progressively replacing normal tissue. And it's sort of like a vicious cycle of autoimmunity, inflammation, vasculopathy, endothelial dysfunction, and then ends up with fibrosis. Perhaps the fibrosis then turns around and creates more of an impetus to this ongoing pathophysiology. So how has the research community attempted to elucidate the problem? Well, animal models, although they have their limitations, genetic analysis, clinical trials, which again, in a rare disease with a heterogeneous phenotype, it's very difficult and lengthy to recruit patients for this kind of stuff. And then biomarkers have been elusive, but what's been looked at are skin fibroblasts, ex vivo, doing serial skin biopsies. And now with the advent of RNA-seq and other big data and machine learning, perhaps this is the way that we're going to be able to understand better what genetic programs are being turned on in these diseases. Okay, so this is my all roads lead to Rome slide. This is sort of a summary from a nice primer in the Nature reviews for diseases, which I recommend. And what they're showing here is all the genes that were picked up in looking at scleroderma studies. And here's your fibroblast in the middle, this sort of square. And then all of these receptors have been implicated. So the master regulator of fibrosis is thought to be Tgf beta. So here's Tgf beta at the top here, interacting with its receptor on the fibroblast, turning on SMAD2 and 3 and SMAD4, which then goes into the nucleus and turns on all these other genes here, resulting in extra collagen being made, other extracellular matrix proteins, and among others. So proliferation of fibroblasts is also turned on by some of the Wnt pathway over here. So there are many ways that culminate. So through endothelin receptor here, ROCK, TLR4, and all of these things then culminated them in the nucleus to turn on profibrotic genes and proliferation, differentiation of fibroblasts. Okay, however, this hasn't really led to any actionable therapies for scleroderma yet. And that could be because there's many players here. So this is another way to look at it. You have tissue injury to begin with, leukocytes infiltrate and become activated. And then normally after an injury, myofibroblasts would come in and lay down some extracellular matrix and allow healing to occur. So, and there are a lot of cells involved here. Again, there are fibroblasts, epithelial cells, fibrocytes, adipocytes, pericytes. All these cells are seen in scleroderma lesions. They become fibroblasts, they lay down the matrix, and normally there would be physiologic wound healing because this pathway is only temporarily activated, and the scar would be resorbed, and that would be that. Normal tissue replaces the scar. But in scleroderma, somehow this does not stop, just keeps going. It's like a maladaptive response to injury, and then it ends up laying more and more fibrosis down. So is Tgf beta the key to scleroderma? Well, it is a potent profibrotic cytokine, induces myofibroblast differentiation. We see Tgf beta dependent genes upregulated in the skin lesions of patients with scleroderma, and it's produced as an inactive precursor protein that is then activated by thrombospondin and alpha V beta 3 integrin. Many signaling pathways are activated downstream of the receptor, so stands to reason. But again, I will show you in a moment the trials, but we can't really use Tgf beta therapies. They're not accepted. They haven't worked. What we do instead is we sort of decide what does this patient have? What's their phenotype and what stage, which organs are involved? And then we have to choose between either immunosuppression, depending. So if we're talking about interstitial lung disease, we can use mycophenolate, we can use cyclophosphamide, we can do autologous stem cell transplantation. I'll talk a little bit more about rituximab and tocilizumab. So that's one approach. The other approach is to look at which complications have occurred and try to mitigate them. So that would be a proton pump inhibitor for GERD, or prokinetic for dysmotility, or antibiotics because they have bacterial overgrowth syndrome. Or you could use a vasodilator because they have severe Raynaud phenomenon with digital ulcers or pulmonary arterial hypertension. Or you could use an ACE inhibitor because they have renal crisis. And now, more recently, we are looking at anti-fibrotics like nintedanib, for interstitial lung disease. OFEV, just kidding, nintedanib. Okay, so what's going on with scleroderma. So there've been a lot of failures, frankly. And it's hard. It's difficult to be a scleroderma researcher. I'm not one. Dr. Spira is, but there's hope on the horizon, but boy, it's been tough. So, okay, let me show you about this one. So immunosuppression. So this is the Scott trial, myeloablative autologous stem cell transplantation for severe scleroderma, not for the faint-hearted. So here is just their main figure showing that when compared to intravenous cyclophosphamide given on a monthly basis, there was improved survival if the patients received stem cell transplantation for their scleroderma. As shown here, overall survival, this is the red line is transplantation, and the blue line coming down here is cyclophosphamide. Event-free survival is a similar trend, separation here. On the other hand, there was a ton of toxicity associated with stem cell transplantation. This trial happened to have a lower mortality than the earlier efforts, but this is something that can only be done in very specialized centers. So what about targeted immunosuppression for scleroderma? Now, this is something that I feel more comfortable. So I'm showing you this slide, which is based on therapy for rheumatoid arthritis, because it shows you where the drugs I'm going to discuss now interact with the immune system. So in the middle here is TNF inhibitors, because these are famous, you know them, adalimumab, et cetera, etanercept. They've been around since 1998, and they really revolutionized the treatment of rheumatoid arthritis. They have many, many effects on T cells, macrophages, this sort of interaction. Though it's important to note that TNF has pleiotropic effects on the immune system. And in some settings, depending what it's partnered with and what the context is, TNF could be stimulatory, like driving the immune response, as it does in many patients with rheumatoid arthritis, or it's playing a counter-regulatory role and mitigating inflammation. And we believe that's what's happening in vasculitis, because even though TNF is expressed in high amounts in lesions around giant cell arteritis, for example, giving TNF inhibitors to such patients has been actually made the disease worse. So we conclude from that in some settings, TNF is actually helpful, is trying to lower the amount of inflammation. So this has not been successful for scleroderma. On the other hand, there are other medicines. So here's rituximab, the anti-CD20 monoclonal antibody, which will deplete B cells that express CD20. That's most B cells, except for the very early and very late B cells. There is abatacept, which interrupts the conversation between, here you can see a T cell, a naive T cell expressing CD28, and a T cell receptor talking to an antigen-presenting cell, which could be a dendritic cell, that itself is expressing co-stimulatory molecules like CD80 and CD86. And what abatacept will do is it will not allow this signal 2 to occur. It will block all of the available CD80, CD86, and not allow the CD28 on the T cell to become ligated. And so that T cell then becomes anergic. So abatacept can be very powerful if a naive T cell response is what should be interrupted. Also interleukin 6. Okay, interleukin 6 here, receptor inhibitors, tocilizumab. So this one will interfere with the interaction between a macrophage and some downstream effector cells. Like in the case of rheumatoid arthritis, it would be osteoclasts, chondrocytes, and in the case of scleroderma, it could be fibroblasts, actually. And here I also have JAK inhibitors, which are used in rheumatoid arthritis, but also inflammatory bowel disease. So let's talk. So this is an appealing concept to try to use targeted immunomodulators to treat scleroderma earlier. So here is a study of tocilizumab in systemic sclerosis. It's a randomized double-blind placebo-controlled phase 3 trial known as FOCUS. It was published last year in the Lancet Respiratory Medicine. And what I'm showing here is the figure where they're looking at the change from baseline for the forced vital capacity as a % of predicted. So as a surrogate for lung function. So in the red line here, you have Tocilizumab, and then the blue line is placebo. And as you can see, this is change from baseline. So the red line is maintaining, if you will, not getting worse over the course of the 48 weeks, whereas placebo is declining. So I'm afraid this is as good as it gets in scleroderma lung studies. You know, if you can maintain the FVC with the drug, then that's a win. Although, of course, you know, it would be great to recover FVC, improve the FVC, but that's not yet achievable. So that is, but that's a hopeful thing. On the other hand, abatacept, which I just mentioned, the TB cell interrupter, was looked at in early diffuse cutaneous systemic sclerosis. This is a phase 2 trial, multi-center, double-blind, randomized, placebo-controlled, also published last year. They looked at 88 patients with diffuse cutaneous systemic sclerosis, both early and established. They gave abatacept weekly for 12 months. This is the standard dosing for rheumatoid arthritis, and they compared it to placebo. And alas, they did not meet their co-primary outcome, which was going to be a change in the modified Rodnan skin score, and they also looked at safety. So it was safe, but it didn't. There was no statistically meaningful change in the skin thickness, unfortunately. What about rituximab? Well, that's going to come out soon. It has not been published. I think the data they have completed the collection, but in this case, they're looking at rituximab versus cyclophosphamide for the treatment of connective tissue disease-associated ILD, recital. So there will be scleroderma patients in there, and they're comparing. So here's their scheme. They're going to do cyclophosphamide on a monthly basis over here, and then give rituximab, and rituximab is given for 2 doses every 6 months. So they're just going to give the doses here, 2 doses, 2 weeks apart, and then they're just going to give placebo for the rest so that the patient is blinded to their arm. And they'll look at the change in diffusing capacity, 6-minute walk test, FVC, DLCO, but their primary outcome measure is again going to be the change in FVC as % of predicted from baseline. Okay, what about anti-fibrotics? It's got to be able to work. It should work. It's the logical choice. We should antagonize transforming growth factor beta, but alas. So here is the 2007 study, Denton et al., recombinant human anti-transforming growth factor beta 1 antibody, metilibumab. This was for systemic sclerosis, placebo-controlled, phase 1/2. Very early, treatment-naive patients were recruited, but they found no evidence of benefit. All groups improved over the 6 months, including the placebo group. So then they thought, well, maybe we just got a group of patients that were going to soften their skin anyway. So that was a bust. And that kind of put a lot of cold water on the whole concept. But it was, and there's another trial from 2015, this time fresolimumab, also an anti-Tgf beta antibody, but it is specific for all 3 of the isoforms, beta 1, 2, and 3. And it, you know, it worked kind of. They looked at skin thickness, they looked at biomarkers, they did skin biopsies, and they did find some decrease in the thrombospondin, for example, and TGF beta, but and some improvement in the modified Rodnan skin score. However, it was open label, it was a small study, and I haven't seen any follow-up to that. So I'm not sure what happened to fresolimumab. Okay. What about this? This was very exciting. Lenabasum, an endocannabinoid agonist. And yes, that cannabis, the one that's in marijuana. But in this case, it's really just targeted to one of the cannabinoid receptors, CB2, which is expressed by many cell types, including in the gastrointestinal tract, vasculature in the skin, and whose stimulation may regulate immune cell function, including T cell subset balance, cytokine production, and cell migration. So a very attractive target in the case of scleroderma. CB1, which is not activated by lenabasum, is the CNS endocannabinoid receptor, the one that results in analgesia and behavioral changes. So CB1 not involved in this study. So preclinical studies were very promising because CB2 is overexpressed in dermal fibroblasts from patients with scleroderma compared to healthy controls. And there was a reduction in Tgf beta and collagen synthesis in response to lenabasum, again, ex vivo, and the very promising phase 2 trials showing a decrease in the modified Rodnan skin score. But alas, the phase 3 study of lenabasum found no significant differences in the primary and secondary endpoints when they compared it to placebo. A lot of the patients were receiving background therapy, maybe that confounded the result, didn't allow to see the effect, and a lot of the placebo patients improved. So again, this is a very tricky situation in terms of how to study effects of a drug when the standard of care is really to give certain things that we know work. It's really hard to defend a situation where you're not treating a patient with scleroderma, just giving them placebo and then trying to compare it to something new. However, they're not giving up. They're going to continue to look at subsets. So hopefully something good will come of this. But in good news here about nintedanib. So this is the nintedanib for systemic sclerosis associated interstitial lung disease, or census trial. So again, nintedanib is an intracellular inhibitor of several tyrosine kinases. I'm just showing you in this cartoon. It inhibits fibroblast growth factor receptor, platelet-derived growth factor receptor, and also VEGF receptor. Here is one of the figures from that study showing again the absolute change from baseline in the forced vital capacity as a percent of predicted. And again, nintedanib pretty much up here in blue, almost holding at the baseline, not a lot of loss of function, and then placebo kind of declining as predicted, as expected in patients with scleroderma. So yes, it is now an option. Question is, what about CellCept? Because a number of patients in the study were on mycophenolate mofetil. And so what they did here is that it's a follow-up study where they looked at subgroup analysis, efficacy and safety of nintedanib in patients with the SSc-ILD treated with mycophenolate, a subset of the census trial. This was published in The Lancet this year. So here you have, in blue, patients taking both mycophenolate at baseline and nintedanib, and they had the least loss of FVC as a percent of predicted. Whereas those who were not taking mycophenolate and were assigned to placebo did not get nintedanib, they had the most loss of pulmonary, of FVC function as a percent of predicted. So that's interesting. So this is mycophenolate by itself. This is nintedanib by itself. And then here's the two together. So perhaps that's the way to go. This is another way of looking at it. This is just showing that the least loss was from the combination of mycophenolate and nintedanib. So maybe that's how we have to think about this. If it's really a vicious cycle of vasculopathy, autoimmunity, and fibrosis, we have to attack it on two fronts to interrupt it. So again, this is just, this is almost my last slide. I just want to let you know that because of the heterogeneity of the disease and the rarity of it, there has been an effort to come up with some kind of composite response. We can't just rely on one feature. It's important to also think not just the FVC, or it's important to also think about how the patient's doing. So they may have different organ involvements and quality of life and responses. So they've come up, this is an expert panel that sort of came up with a composite response index for clinical trials in early diffuse cutaneous systemic sclerosis, or CRIS. Here they're going to use this parameter to look at early diffuse cutaneous systemic sclerosis, because those patients have a rapid change in the skin and internal organs. They're going to use it in trials, and it's a two-step process. For step one, any subject who develops new or worsening of their cardiopulmonary and or renal involvement due to the scleroderma are going to, right off the bat, they're going to be considered not improved, and they're going to be assigned to a probability of 0 improvement. But for the remaining subjects, step two, you can compute the predicted probability of improving for each of them using a very complex equation, which I did not reproduce here. It's a lot of algebra because it's derived from a logistic regression model. And it includes, though, the following things: a change from baseline of the modified Rodnan skin score, the FVC percent of predicted, the patient global assessment, the physician global assessment, and a multidimensional health assessment questionnaire. So as you can see, it's hopefully going to be able to be sensitive and specific to capture improvements in patients with scleroderma. So to conclude, systemic sclerosis, a heterogeneous disease, many pathophysiologic mechanisms, including endothelial dysfunction, immune activation, and these things may trigger and perpetuate fibrosis. I showed you the 2013 ACR Euler classification criteria, highlighting the key features that may help recognize the disease earlier when there is time to maybe intervene and bend the arc of the illness. However, the treatment, I mean, this is difficult. It should be tailored. We have to figure out what stage the patient is in, what sort of manifestations they have, try to target their autoimmune response if it's still activated, deal with the fibrosis, mitigate the vascular dysfunction. And there are novel therapies that are showing promising results, and more coming down the pipeline. So in conclusion, I want to introduce my senior fellow, Dr. Michael Kaplan, who will graduate in June and immediately head over to the West Side to join the Dr. Ali's group. I'm very excited.
We're excited too.
I know he's going to be great, and I'm hoping, not secretly, that we'll be able to expand the rheumatology program once Michael Kaplan has joined, and there's going to be wonderful opportunities for training on the West Side and Morningside. So looking forward to that. Thank you very much for your attention.
Thank you, Dr. Wiesendanger. That was a great talk. I don't know if you were paying attention, but there were a couple of questions in the chat. I'm going to read the first one. This is from Dr. Stuart Greisman from Rheumatology. I'm going to just post the questions, but after we read the questions from the chat, if anyone has a question, please feel free to unmute yourself and ask your question. But Dr. Greisman is saying, TTP, cardiolipin antibody syndrome, pulmonary hypertension, DIC, systemic sclerosis, to some degree have common features, including thrombosis, bland fibrin thrombosis, without much inflammatory cell infiltrates. This is in distinction to SLE and other vasculitides with clear inflammatory cell infiltrates. Do you know any common pathophysiologic features to these clinical syndromes?
Wow. I am not aware of a common pathophysiology, but it seems to me that clotting factors, platelet activation is more prominent, I believe, in those other syndromes. Even though platelet-derived growth factor has been implicated in the pathophysiology of scleroderma, I don't think there's less of a thrombotic phenomena with scleroderma. I don't think it's dry. It may occur secondary to endothelial dysfunction, but I think primarily it's endothelial dysfunction that you see in scleroderma. And if the clots form, that would be perhaps in situ as a result of severe pulmonary hypertension, for example. But I don't think the clotting cascade is as primary in the dysfunction. I don't know if that's helpful or not, but I defer to Dr. Ali if you want to say something.
No, I agree entirely. But I think we have some other questions in the chat, so let's move to those.
Oh, yes.
Yeah, so Dr. Seward, Chair of Medicine, has also a couple of questions. He's saying he's not a pulmonologist, but the CT seemed to include atypical findings for PF. For example, I think I saw ground glass opacities. How are these atypical findings talked about in the rheum versus lung communities? That's the first question. And then I'll go to the second one.
Oh, okay. Atypical findings. Yes, so indeed, so there are different, so the primary type of interstitial lung disease that's seen in scleroderma is NSIP, non-specific interstitial pneumonitis, and it could be more on the fibrotic side. Upon biopsy, you do see fibrotic NSIP. You can see cellular NSIP as well. So what hasn't been so helpful for us is the bronchoalveolar lavage studies have been kind of not that helpful in terms of deciding what is driving that person's disease and what to do about it. So I believe that there is an initial cellular NSIP phase that can then be changed to fibrotic phase. It's hard to tell based on the CAT scan alone, though. I think the radiologists, they do say, ground glass, you would think, is definitely active, maybe more inflamed, more cellular, but it's not always so. So you can be tricked by the CT appearance.
The second part of the question, or the second question, has anyone looked into using nintedanib as a primary prevention strategy for delaying onset of SS IPF?
Not to my knowledge. What we are only using nintedanib for where we know we have established an ILD based on the CT scan and the pulmonary function test. It's not, as you know, these drugs are not easy to take. They have a lot of GI side effects. So I think it might be difficult to sort of sell that to a patient who does not have ILD yet, as a protection. What has been tried is using ACE inhibitors in patients who are high risk for renal crisis prophylactically. And that did not work out. So what happened there is patients at high risk of renal crisis were given the ACE inhibitor. They didn't have hypertension to begin with. And then what would happen is they would develop the renal crisis and it would be masked by the prophylactic ACE inhibitor. In other words, the early signs of renal crisis, which is hypertension, would be missed. And so then they progressed to more severe disease, proteinuria, before it was possible to figure it out. So as far as renal crisis is concerned, we just monitor, and as soon as we detect it, then we bring in the ACE inhibitors. But a protective strategy has not helped for that particular one. So I don't know, Dr. Ali, do you know of any prophylactic anti-fibrotic use? I don't think it's been.
There isn't, but the other point I would make is that 1 year of OFEV cost $96,000.
Oh.
So it's another reason it's, as you know, it's tough to jump over those hurdles to get it, even for people with ILD. But so prophylactically, it won't fly.
That's true.
And there's a third part to the question, which is only if there's time, and I think we have enough time for even more questions.
Yes.
How is the asymmetric decrease to DLCO early in disease understood?
So what I'm told by our pulmonology colleagues is that DLCO reflects sort of the function of the alveoli in a way. So even before the forced vital capacity decreases, you will already see an impairment in gas exchange that's sort of out of proportion to the amount of restrictive disease that you see on PFTs. So it's an earlier sign that something's very wrong with the gas exchange due to the fibrosis that's starting to form around the alveoli. So we do that.
Marguerite, for the residents, we actually do see a fair amount of scleroderma as inpatient, particularly I would say at MSM, and some real severe stuff. So can you comment, because they often come in sort of quote unquote with a flare decompensated with either alveolitis. Can you comment on the whole steroid debacle in scleroderma?
Oh.
Should we use it? Should we not use it? In the studies of OFEV with CellCept, did they factor that in? Did they not use any prednisone? But just maybe for the residents' perspective.
Right. So I mean, the main thing with the thing that's unique about scleroderma is that corticosteroids have not been effective. They just haven't really helped to mitigate the disease, or it's very different, say, in ankylosing or systemic lupus. So that's been a major disappointment. I mean, I guess you could argue that if steroids don't work, well, that means something about the pathophysiology, that we are catching it at a later stage. The inflammatory response is already done its thing, and now we're dealing with the vasculopathy and the fibrosis. On the other hand, are you referring to the cases of high-dose steroids precipitating renal crisis?
Yep.
That's a real problem. I mean, the last thing you want to do is actually exacerbate the situation. So any dose of prednisone that's greater than 10 milligrams is considered risky and not recommended for scleroderma. So we have used very low dose prednisone for patients with severe arthritis. That would be, I think, the only setting in which it's appropriate. So
the lives of these patients with these complex disorders are miserable. And a drug treatment and its monitoring gives them more attention. But are there other strategies that one can use to enhance the quality of their lives separate from medication use? And what can be helpful for these patients? I mean, does moving to the Caribbean with the continuous warmth make a difference to the painful Raynaud's that they have?
well, that would be
Measuring oxygen saturations from Raynaud's fingers is hopeless. It doesn't record.
right. That's true. So, so as you say, there are many sort of life-limiting factors associated with the disease: a terrible fatigue, joint pain, muscle weakness. The Raynaud's can be very disturbing. So, we have to sort of help them find the right lifestyle, like pace themselves, anticipatory napping, so that you can deal with the fatigue and get things done. A lot of them suffer from mood disorders. We can help with that. Maybe certain diets help them. We still don't know what an anti-inflammatory diet truly is, but they do have the gut dysmotility. So if we can help them have a better nutrition and gut function, that would be also helpful. It's tough. It's really, they do suffer. I agree. So a multidisciplinary approach is usually what we try to do. We co-manage the patients with pulmonary and gastroenterology, nutritionist perhaps, psychiatrist, internal medicine, definitely, so.
Yeah, I think we have time for one more question before 9.
No, good.
I have a question. So Marguerite, that was a really great talk, by the way. Really, I just love the way you simplify the basic science. My head goes into a spin when I look at those pictures. But you explained it beautifully. But with the ANA testing that everyone is doing and unanimous, sort of universally in people with arthralgias, you're getting some of these folks that have these SCL70s and anti-centromere antibodies, and they may or may not have nail fold abnormalities, and and they don't have skin stuff, so there may be sort of cine sclerodactyly. What do we do with those folks? Do we follow them annually? Do we put them in a study or reassure them? What's the angle?
So it's tough. So I do like to repeat tests because in a different lab, because just in case, we've had some strange RNA Pol3 false positives that I have seen. I think if the ANA is very low in titer, you might sort of call into question the significance of the ELISA test that's for topo or centromere. But yeah, but I think those patients, perhaps they're in an early phase of something that will progress. So we should be looking for things like getting the echo. I believe we should try to do a careful review system and exam, as you said, and see whether they're developing into a true, because they would not be eligible for a trial at that stage. I'm not aware of any incomplete scleroderma trials going on, like natural history, et cetera. So if they don't have the 9 points, they will not be eligible for any study. So it's up to us to sort of decide when can we interfere. So here's the other thing. With lupus, we don't wait for the whatever number of points. If a person has severe or disease, we're going to start something. We're going to start treating. So I think in clinical practice, we have the luxury of trying to be a little more, we don't have to be so strict with the criteria. We can say, well, I think there's enough here that I want to do something for this person. I think that I'm convinced that there's a merit to trying to give them a treatment. That's what I would say. But again, it really, the blood test is only a potential clue. It has to be taken into the context of the rest of the patient. And sometimes it's a red herring. So,
Dr. Wiesendanger, thank you so much for a really great talk. Echoing in some ways Yusuf's comments, I loved all the emphasis on the physical exam. So much that we can do in the room with the patients. And just to echo your comments, we're really excited about Mike Kaplan and really excited about new opportunities for collaboration. So thank you again. It was wonderful having you here today.
great. Stronger together. Thank you, everybody, for your questions. Thank you for inviting me. It was a real pleasure.